Welcome to the Cardiac MR Learner Series, a unique video tutorial program under the aegis of Indian Association of Cardiac Imaging. This program is focused on beginners and intermediate images with learning happening through short sessions and case-based discussions. We are grateful to experts from different parts of India who have helped us in putting this program together. Please do feel free to give us your feedback so we can continually improve such training opportunities. Today's presentation is by Dr. Major Vimal Raj, who is the Head of Radiology and a consultant cardiothoracic radiologist in Narayana Institute of Cardiac Sciences, Bangalore. He is an expert in adult and congenital cardiac CT and MR imaging and also has special interest in interstitial lung disease and pulmonary hypertension imaging. He has published more than 75 articles in peer-reviewed journals and has textbooks on FRCR and HRCT under his belt. He also holds a patent in postmortem CT coronary angiography catheter design and has been awarded a medal by the NATO for his operational service in Afghanistan. He is a convener of Cardiothoracic Imaging Fellowship in NH Bangalore. Welcome to this session on stress cardiac MR. The objectives of the session are to establish the role of stress cardiac MR in day-to-day practice, explain how it is done, and how does it compare with SPECT perfusion imaging, and to show some cases. It's important to understand the ischemic cascade. The standard presentation of a patient with coronary artery disease to the hospital is with angina, which is much later in the disease process. It is ideal to be able to pick up the disease at a much earlier phase where treatment can be instilled. Perfusion abnormality is one of the first few things which are easily detectable in patients with coronary artery disease, which are followed by diastolic dysfunction, systolic dysfunction, and then ECG changes and angina. The principles of stress perfusion imaging are very simple. If you consider these as two branches of a coronary artery, and this yellow spot to be a calcified or a atherosclerotic plaque in the coronary artery, in normal status, this, let's say 80% occluded vessel manages to supply the myocardium at rest without any problem. During a physical activity session or during any form of stress where there is increased myocardial blood flow, the vessel which has got significant coronary artery disease is unable to cope with this increased demand because of the disease, and compared to a different myocardium, the myocardium which is supplied by the diseased vessel will have hyperperfusion. These forms the basis of ischemia testing in patients with coronary artery disease. Who should be having stress cardiac MR? Well, patients who have known coronary artery disease of indeterminate significance, for example, a patient who's got a 70% or 80% stenosis with atypical symptoms, or patients who present for the first time with dilated cardiomyopathy of unknown cause, whereby coronary artery disease is one possibility. Stress MR is excellent in these patients because it not only will exclude or diagnose coronary artery disease, but it will also look for non-ischemic causes of dilated cardiomyopathy. It is also useful in patients who have intermediate to high risk for coronary artery disease and are being tested for coronary artery disease. So, for example, if a 70-year-old diabetic and hypertensive walks in with stable chest pain or atypical symptoms, rather than getting an invasive catheter angiography in this patient, it may be better to do a stress cardiac MR and decide further management of the patient based on the findings of the stress MRI. What does a clinician want? If you see a patient with suspected coronary artery disease, the clinician wants to know, is there ischemia? If there is ischemia, which vascular territory is involved? And if there is ischemia and we know it is in a specific vessel, is that territory viable? If this is not at all ischemia, what is this secondary to? Now, we have dealt with the issue of viability and non-ischemic cardiomyopathies in other sessions, so we will not be talking about them here, but we will be talking about assessment of ischemia and the vascular territory. As far as cardiac MR is concerned, ischemia can be tested by either first pass perfusion or wall motion abnormality. We use vasodilator stress. Adenosine is the most commonly used drug to induce vasodilatation. It is known to have secondary effects of dyspnea, chest pain, and AV block with some bronchospasm due to its involvement of the A2A receptor. It is imperative to select the right kind of patients before giving adenosine. We avoid patients who are asthmatics, people who have AV blocks or LVOT obstructions. Another drug which can be used is Adenosine. This is a highly selective A2 receptor agent, so there is no bronchospasm or AV block related complication in these patients. However, it is not available that easily in India at this present moment. So if a patient is given adenosine stress perfusion cardiac MR appointment, we make sure that the patient is 24-hour caffeine free prior to the procedure. The ECG is evaluated for AV block. Patient is asked for asthma history, and the lungs are examined for any active Vs. Imaging protocol consists of routine cine images, which are followed by adenosine stress imaging, whereby adenosine is infused for 3 minutes at a dose of 140 microgram per kilogram per minute. 2 venflons are put in patients, one in each arm. The arm which receives contrast is the same arm as the BP cuff. Active monitoring of the heart rate and blood pressure is done during the perfusion. Adenosine is injected through an arm which does not have the BP cuff. Heart rate and BP is monitored regularly. Symptoms are recorded during the perfusion, and at a point where adequate stress response has been achieved, which is fall in blood pressure and raise in heart rate, or patients having symptoms of chest pain, flushing, or headache, then contrast is injected and first pass perfusion through the myocardium is seen. Rest imaging is performed about 15 minutes after stress, where no adenosine is infused. Post-test, patient parameters of heart rate and blood pressure are monitored, and patient is discharged if he has no symptoms. Adenosine infusion is being found to be very safe in all clinical practices, and in our own experience, where we have done more than 1,500 cases in the last year and a half, it is extremely safe if we triage the patients appropriately. The scan protocol consists of localizers followed by black blood images and cine images. T1 and T2 mapping sequences are performed. Stress perfusion imaging is performed, which is followed by cine short axis stack, delayed enhancement imaging, and post-contrast mapping. Q-flow images are also performed, and next set of rest perfusion images is performed to compare with the stress perfusion images. Let's look at one example. This is a case where we have done stress perfusion followed by rest perfusion. The stress perfusion images are in the top, where you have basal, mid, and apical cavity short axis images. It is very important for first pass perfusion that all images are acquired within 1 hour to hour interval. So if the heart rate is high, it is possible not to acquire all the 3 images, and you may have to reduce the resolution of the image to achieve that. If the heart rate is low, you can get the basal, mid, and apical short axis images and also a 4-chamber image as part of the first pass perfusion. Now, in this image, what you would see is the contrast first enters into the right ventricle, then into the lungs, left ventricular cavity, and then through the coronary arteries into the myocardium. And what we are looking for are areas of hypoperfusion. These areas are then compared with the same area at rest, whether this is a fixed perfusion defect or this is a inducible perfusion defect. This is a different case example where we are showing area of perfusion defect in the septum and anterior segment extending into the inferior segment, while on rest images there is no perfusion defect, suggestive of a reversible perfusion defect in keeping with ischemia. Another method of assessing ischemia is by looking at inducible wall motion abnormality. This is done with dobutamine, where incremental dose of dobutamine starting from 5 microgram per kilogram per minute is increased up till 40 microgram per kilogram per minute, or to a point where target heart rate is achieved or a new wall motion abnormality is induced. We do 2-chamber, 4-chamber, and short axis 3-level images at rest. We start dobutamine perfusion, we continue it for 3 minutes, and then we repeat the 2-chamber, 4-chamber, and 3 short axis images while dobutamine perfusion is continuing. After this is done, we further increase the dose of dobutamine and repeat the whole process until a point where target heart rate is achieved or a wall motion abnormality is induced. If you can look at this case, this is a patient who has got RCA territory disease, and what we can see at rest, there is wall motion abnormality in the inferior segments, and as we increase the dobutamine dose, the inferior segment contractility is improved and there is no new wall motion abnormality, suggesting that the inferior segment is viable and there is no inducible ischemia in any other segments. The next question comes is vascular territory. Vascular territory determination is on a 17-segment model in collaboration with the coronary anatomy in the angiography images. The segments along the anterior and anteroseptum are usually supplied by the LAD and the lateral wall and lateral segments by the circumflex, while the inferior segments and the infroseptal segments are supplied by the RCA. This is not reproducible in every case because patients who have left dominant supply may have inferior segments supplied by the circumflex, while a large RCA may even supply some of the infralateral segments. Cardiac MR is far superior to SPECT with multiple large center trials such as MR Impact and CE Mark study showing that stress MR imaging is superior to SPECT, and it has got significant prognostic value also on top of SPECT imaging. Let us summarize what we mean in terms of inducible ischemia. A normal myocardial segment will not have a stress perfusion or rest perfusion defect or delayed enhancement. A myocardial segment which only has ischemia and no infarction will have a stress perfusion defect, but there will be no rest perfusion defect or any delayed enhancement. A segment which has got infarction will have perfusion defect at both stress and rest, and the same corresponding area will also have delayed enhancement. Areas which have peri-infarct ischemia will have
delayed enhancement in the infarcted segments, which will be similar to the rest perfusion defect, whereas the peri-infarct zones, which also have ischemia, will show stress perfusion defect. So whenever we report the cases, it is useful to compare all of these three parameters to come to a conclusion whether the segment has got inducible ischemia or a fixed perfusion defect. Let's look at this 55-year-old male who has got triple vessel disease, whereby RCA had 70% stenosis, circumflex 90%, and LAD had 80 to 90% stenosis. Top images are cine images where we can see that there is good wall motion with no areas of hypokinesis or akinesis. The bottom set images actually do demonstrate delayed enhancement, showing small subendocardial infarcts in areas of mid to apical anterior segments. So these are the stress perfusion images and the rest perfusion images at the bottom. I'll let these images run one more time, and where we can see that there are areas of perfusion defect along the anterior and the septal segment, and also along the infralateral segment in the basal cavity. Representative images of the stress perfusion do demonstrate areas of hypoperfusion along the basal infralateral segment with no corresponding rest perfusion defect. In the mid cavity, you can see the anterior, inferior, as well as the septal segments have got perfusion defect with no corresponding defect in the rest images. And again, in the apical cavity, apart from the lateral wall, most of the apical cavity does demonstrate areas of perfusion defect. So, in conclusion, we would have said there is inducible ischemia in the anterior anteroseptal segments and also infralateral and inferior segments, in keeping with triple vessel disease, and all the vessels have significant inducible ischemia. Let's look at this second case. This is a 65-year-old male who's got total occlusion of the right coronary artery. LAD had 90% stenosis, LCX 60% stenosis, and an OM1 branch had 80% stenosis. So again, we look at the functional images at the top and delayed enhancement imaging at the bottom. What we can see are these areas of subendocardial infarction along the anteroseptal segment, apical septum, to some extent in the anterior segment. The same areas do demonstrate hypokinesis, otherwise the wall motion abnormality is preserved. So if we were just assessing the viability, we would have said all the segments are viable. These stress perfusion images, followed by the rest perfusion images, are showing us areas of hypoperfusion on stress imaging involving the mid and apical septum, with some area of involvement of the apical anterior segment, mid anteroseptal with mild extension into the anterior segment. Let's look at some of the representative images. Here we can clearly see areas of perfusion defect in the mid and apical septum, extending into the inferior segment and apical anterior segment, where you can see the area of infarction is much smaller than the area of perfusion defect. So these are areas of peri-infarct perfusion defects, suggesting that there is infarct as well as ischemia in these segments. Gibbs artifact or rim artifact is something which we do encounter in stress perfusion imaging, whereby there is a thin rim of dark signal, often circumferential, at the interface of the endocardium and the LV cavity. These are easy to differentiate in most cases because they are razor sharp and do not fit to any vascular territory. In summary, stress cardiac MR is a one-stop shop assessment for ischemia, ventricular function, myocardial viability, valvular assessment, and also surgical planning. It is far superior to SPECT and is a safe procedure if adequate preparation is taken in selecting the patients and monitoring the patients well during the procedure. Thank you very much for patient listening. Please do feel free to reach out to us to share any comments or suggestions. Thank you.